Thank you again for inviting me to talk about multidisciplinarity. Many things have been already said in the previous speeches. Just to recall, among others, the consensus statement on quality of cancer care undersigned by ASCO and ESMO, so the American Society for Clinical Oncology and the European Society for Medical Oncology, on the two sides of the Atlantic, on quality of care, and it states very clearly that any cancer patient has the right to a multidisciplinary approach to his cancer. The reason is very simple, I think, because simply because most cancers today are treated through more treatment modalities, so surgery, radiation therapy, medical therapy. So in a sense, I think we wouldn't have so much need to demonstrate formally the efficacy of multidisciplinarity, because I mean it's in facts. I absolutely agree that multidisciplinarity doesn't involve only the surgeon, the radiation oncologist, the medical oncologist, but also the pathologist, also the radiologist, and also other members of the cancer team, nurses first of all, but also rehabilitation experts and so on, and palliative, even social workers and so on. So really the multidisciplinary cancer team is a very complex enterprise, and it's not made up only of physicians. Clearly, tumor boards may be more important in those diseases which are more complex to treat and which have more treatment modalities to integrate in most cases would deserve a multidisciplinary team. And indeed, countries have wondered if multidisciplinary care was functioning properly when they decided to re-examine the way cancer care was delivered. One criticism could be, okay, but in the end, in cancer, we have clinical practice guidelines, we have algorithms like this. I mean, it's just a matter of following rules. Okay, you may have an algorithm saying that if you have lung metastasis, you must do this. If you don't have lung metastasis, you do that. But it may be not so easy to say whether this is a cancer, a lung metastasis or not. It depends. It depends on the history of the patient. It depends on several things. You need a radiologist. You need the clinician. You need that they speak together to make a decision, overcoming an uncertainty which may even remain after some further assessment. So uncertainty is in the everyday clinical practice of all of us. The clinical case may be complex. The patient may have another disease. You may not be so comfortable with giving the standard chemotherapy. The case may be atypical. Maybe all rare cancers could be considered atypical. The patient may express preferences by which the standard treatment is unfeasible simply because the patient doesn't accept what is standard. So all these things make algorithms in clinical medicine difficult to use, problematic. It's one of the reasons why sometimes evidence-based medicine may fail to assume that you go directly from the clinical trial to the patient's bedside. because there must be a mediation, and this mediation is done by the physician, but it's done by a team of physicians when you have to put together several treatment modalities. So this is the reason why multidisciplinary discussions are so useful. Many of our decisions could be formalized much better through decision analysis, which are more complex because you must combine probabilities, utilities, and so on to overcome your uncertainty. Indeed, the everyday clinical decision-making of all of us lies between the model of algorithms, which is very simple, and the model of decision analysis, which is very complex. All our decisions, in the end, stay in between these two extremes. But this is the reason why multidisciplinary discussions are so important, especially for some strategic clinical decisions in the patient's history. There are some points in the clinical history of a patient when the clinical decision is everything, because that clinical decision will affect the outcome of that patient. I mean, if you are wrong with that decision, possibly you lose something. So there are maybe one decision or 2 or 3 decisions or so in the clinical history of the cancer patient, which are so important. And it would be a shame if just because the patient is seen by the surgeon and not the radiation therapist, that he's treated with surgery and not vice versa. So even when the decision should follow a standard, having a tumor board, a multidisciplinary committee, or whatever, however you want to call it, may make a difference. So just to check, in this case, if the algorithm is properly followed. So there are 2 main reasons why multidisciplinary tumor boards are important. Just to be consistent, just to check that the state of the art is followed properly, and to discuss all what goes beyond the state of the art, because medicine is complex. Tumor boards, because these multidisciplinary committees, as has been said before in the speeches of the previous session, quite often have to do with single tumors, because people specialize in single tumors. So there are multidisciplinary committees focusing on single cancers. This is a challenge for the organization of a hospital, of a cancer center, and so on. Because we have an organization which is based on units, departments, which are based on disciplines. So you have a surgical department, a surgical unit, you have a medical oncology department, you have a radiation therapy department. But then you have this kind of tumor boards which cross this kind of organizational pattern. So you have a matrix organization which is complex to run, because hierarchically it's easy to run, if you want, a surgical or a medical oncology or a radiation oncology unit. There is a chief who takes the responsibility for everything. But when you have a tumor board, yes, you may have a coordinator, you may have something like that, but everything is different. And by the way, you must involve those persons within the units or the departments who specialize in that tumor. So even the organization of the unit or the department should fit this model. And this is another challenge. But the main challenge is this, that in the tumor board, everything must be decided by consensus. So there is not a chief. There may be a coordinator, but all decisions must be made by consensus, because we may decide to do radiation therapy, but if the radiation therapist disagrees, of course, radiation therapy will not be done, and that's it. So the tumor board must learn to work smoothly by consensus. And you know, the psychological aspects of people working within these tumor boards may be very, very important, because tumor boards, these committees are groups, so the psychology of groups applies to all this. And this is the reason why I agree that psycho-oncologists should take care not only of patients, but also physicians. Not only for their burnout and so on, we know these problems of caregivers, but also because these aspects of group psychology and so on may become so important and may even paralyze a tumor board. By the way, there are medico-legal implications. When a tumor board makes a decision, all the people of that tumor board undersign the decision. So some of them may agree on the decision, some others may not agree so much, but finally the decision is a decision by consensus, which entails the responsibility of all of them, even from the medico-legal point of view. And then the other challenge is that the patient willingness counts. So the good clinical decision today, in today's medicine, is a patient-physician shared decision. It's not just an informed consent. The decision itself should grow up, should be shaped in such a way as to reflect the values and the preferences of the patient. So you should bring within the discussion in the tumor board the patient's preferences. So we need someone who takes care of this before the discussion. And then the outcome, the output of the discussion should be brought to the patient and discussed further with the patient. So probably we need a reference physician, possibly maybe one of the physicians of the tumor board. The physician will be more involved in the treatment program which has been selected, I don't know. But we need a reference physician for the patient, because otherwise you have a dilution of responsibilities which may be very harmful for the patient and for the shared decision-making with the patient. In the end, all this implies extra medical time. So you need to have more medical time, and this means money. I agree with what has been said before, that in the end, multidisciplinarity implies money. Of course, you may even spare money because the output will be better, because, of course, but for the moment, I mean, a hospital must put money in all this. And this is a challenge, of course, in these times. A hospital may say, okay, but should I have a tumor board for all cancers? At least for frequent cancers. At least for these 5 groups of cancers, perhaps. I am talking about solid cancers, of course. Then there are hematological cancers, of course. Then there are rare cancers. You may say that these are the rare solid cancers. You may also classify them a little bit more in depth. It's reasonable that these cancers should be dealt with by reference institutions. It's difficult for any hospital to have tumor boards for all of these cancers. But this means that you switch from the notion of the reference center to the notion of the reference network. So you put several institutions together to give rise to a network. And this is particularly important for rare cancers. This is my experience. I am a medical oncologist. I am a clinician. I follow sarcomas, basically. By the way, rare cancers include pediatric cancers, include hematological cancers, or most of them, if you want, aside from lymphomas, but then lymphomas are split into a lot of cancers, and rare solid tumors. So the sum of all these cancers gives rise to 1/5 or so, 20% or 25% at least, of cancer cases. So this means that rare cancers are all but rare. They are frequent overall. They are rare individually. So they are a big problem also from the quantitative point of view, quite paradoxically. And you know, anyone says today that with targeted therapies, also frequent cancers are becoming rare because you must split them into a lot of different entities. This means that what we learn in rare cancers from the methodological point of view, from the organizational point of view, may be useful in the near future also for frequent cancers. We discussed some of these issues in Brussels at the end of 2008. It was a multidisciplinary meeting with the industry, with the regulators, with the health administrators, with clinicians, researchers, and so on. And we discussed about some methodological problems of clinical research into rare cancers. We discussed about the organization of healthcare on rare cancers. We discussed the issues of patient access to new drugs and new treatments in the rare cancer field. We put all this into some recommendations, which you may find on the web. And now we are pursuing an initiative based on these recommendations. And we must be grateful to Spain and to Dr. Borras because some of this has been put into the European Union Partnership Against Cancer. Spain is coordinating one of these of the work packages within this European effort. And so, I mean, this is something which may be helped by this kind of partnership among all the stakeholders which are in place when we talk about rare cancers. You may also undersign these recommendations if you agree on them, of course. The key point of the recommendations on the organization of healthcare was networks. Networks are crucial for rare cancers for the reasons I tried to mention before. My experience, my personal experience, has to do with the Italian Rare Cancer Network. We are following basically sarcomas, but we are expanding the spectrum of tumors followed by the network. The network is working, has been working for several years now. It's based on clinical cases. So, for example, one patient may have his case discussed virtually over the network by 2 or 3 centers of the network. Then the patient may do chemotherapy somewhere in Italy. Then his case may be rediscussed over the network, and then he may move to receive surgery or radiation therapy elsewhere. So there are some network patients who will be followed according to some rules, to some clinical practice guidelines, which we decided on the network. These are logical network patients. And then there are some patients whose case is discussed virtually over the network, but the patient doesn't move. These are virtual network patients. And then there are some patients who move across the network more rationally than they would have done if they simply would have followed the kind of health migration which, you know, is a problem in Italy, from southern Italy to northern Italy in particular. So there are some logical network patients, virtual network patients, real network patients. The same patient may be one or the other, depending on the time. And indeed, we should get used, I think, to this notion that in a network, certainly the information moves over the network by definition. I mean, networks are just the product of information technology. But then also patients may move across a network rationally. And then also physicians may move because, for example, the surgeon of a clinical center may move one day of the week and go somewhere else in the network and operate some patients elsewhere. So networks are becoming something quite complex because these three things move across the network today. And so also the multidisciplinary tumor board becomes something virtual in a sense, so something which works over a network. Clearly, there are some things which you can do over a network, something which you cannot do virtually, but this is the reason why someone must move. Our model has been the distant patient sharing between 2 or 3 institutions of the network. So between a peripheral center and a center of reference for that disease. Fortunately, this kind of things are not real anymore. So now it's much easier to share information. We work on a web-based tool, somewhat sophisticated, but now we have a lot of softwares which allow a lot of things. For example, teleradiology is very practical, even because many times the clinical question will not be radiological, it will be surgical, for example. Is this patient operable or not? So probably you don't need even the most sophisticated software of teleradiology. Even telepathology is possible, is feasible today. We decided not to use it for a couple of reasons. The first one is that, yes, today you can scan a slide and you can share it. The reference pathologist may move the slide and may see the slide at different magnitudes and so on. Unfortunately, there are 2 problems. The first one is that the reference pathologist may be willing to do immunohistochemistry again, and this is not doable with telepathology. And the second one is that, unfortunately, today, the equipment to scan the slides, generally you find these equipments in the reference centers, but not in the peripheral centers, which should send the slides. So we decided, at least for the moment, not to use telepathology, but pathology is a crucial element of our network. Probably the most important service we are providing. These are 4 cases of sarcomas or so. You see, they are not that different. I mean, at least the non-pathologists may. And indeed, they are 4 completely different things from the therapeutic point of view, because treatment today is completely different for these 4 things. And so you may understand why the number of cases in which something has changed because of the pathologic second opinion is impressive in our network. But the same happens in France, the same happens in all the countries. So when you go to rare cancers, the pathologic diagnosis may be a problem, simply because the pathologist is not used to seeing so many cases. So the second opinion pathologic diagnosis is crucial to guarantee good quality of care. Because, you know, in oncology, our diagnosis is the pathologic diagnosis. We don't have a clinical diagnosis. This is different from other clinical branches. we have the pathologic diagnosis. If the pathologic diagnosis is wrong, everything is wrong, will be wrong. Again, extra medical time, extra money. Certainly the cost efficacy of networks in the end will be favorable. There may be a problem, a kind of cost shift, I would say. In particular, from some social costs, which are the costs of health migration, which are paid by the patients, basically their families, the society, to the costs of networks, which are not technological. They are all about the extra medical time, which is spent by working in a network. So basically, some social costs are converted into health costs, and this may be a problem, even if in the society perspective, this pays off, of course. Then someone may wonder whether the efficacy of networks has been proven formally, or the efficacy of multidisciplinary teams. You know that in terms of evidence-based medicine, we don't have so many proofs of efficacy, even of tumor boards of multidisciplinary teams. I don't believe, however, that when the telephone was invented, they did a lot of cost efficacy efforts. Simply the telephone was used. And this is also a problem, of course. Something may not be so good in this. But simply the information technology is producing networks, and networks are growing up. We should learn to use them, I think. I talked about the rare cancer network in Italy, but I'm involved also in a regional network, which is not focusing on a single group of cancers, but on all cancers. It's based on the information system of my region, the Regione Lombardia, the Milan region. And this information system allows us to see currently as a PDF file all the patient discharge reports from hospital and the outpatient clinic visit reports, but as PDF files. So we decided to go beyond this and to make all this a kind of database. It's not properly speaking a database, but it works like a database. Of course, having a database changes everything, because if a document is a collection of fields of a database, you can do a lot of things more with that document. So we tried to identify some fields for these documents, which basically have to do with what you did to that patient during his stay in the hospital, or during his visit, or during day hospital therapy, and so on. So we identified some fields which describe well the patient's history, and we were able to agree as oncologists in the Lombardia region on the same semantics. So basically, in the near future, all patients in Lombardia should be discharged from their hospital or from their visit with a document with the same semantic in a format which is the format of a database. And by the way, some of these fields have to do with a treatment decision which has been made about the phase of disease in which the patient is. You know, tumors lend themselves to be split into phases, because you have the phase of the localized disease, you have the phase of the first metastasis, if the patient is not cured, of course. You may have the phase of the second chemotherapy, the terminal disease, and so on. You will see the patient a lot of times during these phases, but each of these phases will be marked by a crucial treatment decision. The kind of decisions I mentioned at the beginning, which may be crucial for the patient's outcome. So we tried to shape our clinical practice guidelines based on these tumor phases. This allowed us to, again, this was a consensus work in the community of the oncologists in Lombardia. This makes it possible to interconnect the role doc, the document I am describing, with the clinical practice guidelines. This may allow us in the near future to make some assessment on a population basis of the appropriateness of this kind of crucial treatment decisions. So during the localized disease phase, the decision was to treat the patient with surgery and then chemotherapy and radiation therapy. This was the strategic decision. This kind of decision may be cross-checked with the clinical practice guidelines. And so you may have an idea of how the treatment has been appropriate for that patient. Of course, we don't expect a 100% appropriateness, but this simply depends on the fact that you must individualize your decision, and in fact, you need the tumor boards and so on. By the way, the same document can be used for a teleconsultation service. So when the clinical practice guidelines is not sufficient, you resort to a virtual multidisciplinary tumor board. Then we are putting other services, for example, a service of virtual tissue banking. There are a lot of difficulties in things like this. And paradoxically, in a sense, the current data protection regulations are a challenge for this kind of networks. And this happens throughout Europe, so not in a single country, but in many countries in Europe, in one country more than others perhaps. And then the other problem has to do with ourselves, because we tried to agree on the same medical semantics, but this is far from being shared worldwide. In the end, the information technology allows us to interconnect the databases quite easily from the technical point of view. But then, if our semantics is different, if I call the patient history in one way and another physician in another way, if I put only those things which have to do with cancer and the other physician puts also the other thing. I mean, if we don't have a common medical semantics, this will be a very important problem for all these networks. And this has to do with ourselves, with scientific societies, with physician communities. So in brief, what I tried to tell you, nothing new. Multidisciplinarity is imposed by the multimodal approach to most cancers. Multidisciplinarity implies to have physicians talking with each other in the same room, even visiting the patient together, because involving them one by one is not enough, in many cases at least. This is a challenge. This challenge will be more and more played within networks. So we should get used to networks. Of course, there are some things which are a priority for networks. Rare cancers is a good example. But networking is spreading to manage cancer care in general, also, for example, at a regional level and so on. In the end, multidisciplinarity should pay off, at least if you put yourself in the patient perspective or in the society perspective. Thank you.